So I'd like to start with you, Professor Stephen King. So share with us your views on why the need for competition in and contestability in human services, and will it achieve the outcomes expected?
Okay. Thank you, Lucille. For those of you who haven't had a chance to look at the Productivity Commission's preliminary findings report, it's a good read. It's not 400 pages. It's a fairly short read. It's the first stage of a two-stage process that we're going through, following on from Harper, looking at, and I'm going to add another set of words, user choice, competition and contestability. Now, I deliberately put it around that way because the starting point, in my opinion, for thinking about human services is to think about where can we allow more user choice, and then how do we design a system that enables the users of the services to be empowered to choose the services that best suit their needs. And then once we've got that focus, we can then ask, well, how do we provide the choices for those individuals? Is that through a competitive system where we have alternative providers in the marketplace, in a marketplace that is often set up, and to use a word that the Mandarin said yesterday wasn't necessarily well defined, stewarded by the government, really set up, maintained, regulated by the government to ensure that the users are protected appropriately? Is that the way we go, through a competitive approach? Or do we need a more contestable type approach where competition isn't practical, so that the government chooses who will be allowed to provide, say through a competitive tender, and possibly what the range of services are that are available for the users? So why is this a good thing? Why is user choice a good starting point for human services? Well, I think you just need to ask the people who receive the human services to find out that too often our approach to helping people has been to tell them what is good for them, rather than to ask them, what are your objectives in life? What do you need? How can we assist you? Because in general, they know best how to help themselves. They know best what they need. And so this user choice with a competitive backdrop means that, like in other markets, we will see different providers, not-for-profits, mutuals, government, and, to mention the evil word in some people's ears, for-profit companies, being motivated by the users of the services to meet the needs and the requirement of those users through innovative service delivery, through thinking about things that, quite frankly, bureaucrats or people sitting at the top of those organisations but without seeing what users need simply would not be able to do. Now, the final point on the introduction, user choice, competition and contestability are not always appropriate. It's easy to think up examples. If you're in a situation where a woman with a couple of children are in need of emergency accommodation, that is not a situation where user choice is often going to be relevant. They are in an emergency situation. They need services now. They're not in a situation to be able to make a choice. We don't expect people to be on the way to the emergency department in the back of the ambulance saying, you know what, I reckon that's a better hospital over there. How about I go there rather than the one you're taking me to? If they're conscious, they're certainly not going to be in a situation to be making that choice. So user choice is not always appropriate, but where it is appropriate, what we're looking at with the PC's inquiry is how we can bring that into the marketplace, how to bring that into human services to help empower the people who receive those services.
Thank you, Stephen. Rowan, coming from Australian Unity, a provider of human services, health and aged care, as well as disability care, what reflections do you have on Stephen's comments? I'd certainly like to hear the practical side of the equation, and where do you think effort is best applied in order to increase the effectiveness of human services?
Thanks, Lucille. I think in some ways anything I say today is a sort of, I hope, practical footnote on the points raised by Nicholas Gruen at the opening and by Martin Parkinson last night over dinner. So these are thoughts really from the coalface in terms of an organisation trying to provide services to an ever-growing set of needs. Growing needs either because of policy, implementation, policy change, in the case of the NDIS, or because of demographic needs and other needs. So I might just proceed by 3 quick segments, if I might. The sort of size of the prize, the nature of the problem, and reasons for positive optimism, if I could sort of break it up in those categories. Just from as a sort of practitioner and deliverer, the thing that we see day to day is a very real expression of the fact that we will be amongst the first human societies to witness mass ageing. Every day we get to work and we see the consequences and the outworkings on many dimensions of the ageing, sickening, thickening population. And we also have a context there where, in terms of recent economic performance for Australia, we've got an additional and very important context, which is household income for the largest proportion of Australians is going nowhere in terms of growth. And in that context, addressing all of these challenges becomes particularly problematic, potentially at a policy level, but it also means that the field is suffused with rightful anxieties and concerns about where people's position will be at the end of any changes or reforms or disruptions. So just on the size of the prize, just one segment which is important. We had the AIHW reports last week, which are a year out of date, but we saw their recurrent expenditure, not gross expenditure, but recurrent expenditure in health at some $152.1 billion across all payers, that's governments, individuals and others. And just the delta year on year over the last year was just under $8 billion in recurrent expenditure, gross expenditure even larger. So when you think about that number as the growing outlay per annum, and you think about some of the references that we had in earlier discussions and last night and yesterday about sort of $6 billion savings over 4 years to federal budgets, we need to make sure that we put this in the proper context and we understand the scale of the mountain that we're addressing. That's just healthcare. Health and social assistance, the dimensions go beyond obviously just the purely financial elements. Health and social assistance as a workforce category is Australia's largest workforce segment. So now some 1.5 million workers. It crested retail and construction some 2 or 3 years ago. And just in terms of 10-year average increases in workforce dimensions, we've seen about 23,000 jobs added per year on average in the healthcare and social assistance space to reach that 1.5 million or so workers. And we've seen about 8,000 10-year jobs added in the mining and resources sector over a 10-year period on a 220,000 or so installed base. Noting, of course, that given the change in the investment dynamics in mining and resources, that sector actually shed 23,000 jobs year on year last year. We've got the NDIS, which is a noble but very substantial policy agenda with all sorts of execution risks, some of which are coming into public consciousness. But its target, let's remind ourselves, is to address the needs of some 400,000 Australians, and I'll let you work out the ramifications for likely workforce and other involvements that's going to mean. And that will be some $22 billion in funding that is not currently discharged from the federal budget. That's growing from effectively zero from this year. And in terms of the point on mass ageing, we live in a world in Australia where 330 people turn 65 per day. So the relentless nature of this, and that's accelerating, the relentless nature of some of the policy challenges and service delivery challenges are very significant. Then we get to the nature of the problem. In relation to this, I sort of try and draw a distinction between technical and complex problems versus adaptive challenges. And it seems to me that the challenges that we're discussing, and the Productivity Commission is grappling with, and that Ian Harper's report was on about, are essentially adaptive in nature. They don't have certain solutions. We haven't been there before. We're an untravelled country. They're super complex as well, but so's, building a jumbo jet. It's complex, but we know how to do it. Some of the stuff that's in front of us here is complex and we don't know how to do it. And that requires a whole different apparatus of policy and execution activity. So the danger for us is, for example, in healthcare, how do we just avoid building in Henry Ford terms, how do we avoid the faster horse? Because the faster horse isn't going to help us. We actually need something materially different. So the example I use, and you could use it in a variety of areas of human services, but is, I like the thought experiment of summoning Alexander Graham Bell from the grave and taking him to an average Australian middle-class household and asking him to identify, identify the telephone. My suggestion is that Alexander would be stumped. But what's more, when we actually pointed the device out to him, he would be even more profoundly amazed, because it's not just that there's been technical innovation in terms of scale, miniaturisation, etc., reach, etc., but think about the business model issues that have been swept up along the way. What are the implications in this device for people who used to publish roadmaps, restaurant guides, etc.? So, whereas if I ask Florence Nightingale to leave her rest and come to an acute hospital, I would suggest to you that the business model, while there's been technical innovation, there are ear thermometers now and the charts are slightly computerised occasionally, but I would suggest to you that Florence Nightingale would look and scan the average acute hospital operations and find something that is remarkably resonant with the 150 years ago experience of hers in the Crimea. And in fact, some 150 years ago, Florence famously said, if I could find hospital records that meant something, a great deal of human good could be done and a great deal of human harm might be avoided. We're still waiting for that sort of moment 150 years later. So, but the serious point here is to try and distinguish between the massive technical innovations that we've seen in some of these areas. For example, in healthcare, we've innovated molecules, procedural approaches, devices. All these things have marched on tremendously to great human benefit. But in terms of service models, business models and approaches, I would suggest that we haven't, and I think that needs a different apparatus of change. So if I could just quickly finish, I've been over long, reasons for positive optimism. The size of the prize, the opportunities here are huge. In my view, just healthcare alone represents a $20 billion per annum saving, potentially falling off a log. And that's not just saving for cost efficiency's sake, that's a safer, higher quality, more appropriate, more patient-centred healthcare system to boot. I think, and in that I'm a student of Donald Berwick's triple aim in relation to the possibilities of healthcare systems. But the other dimensions that are quickly changing the nature of this conversation are the rise of the emergence, and it's very much just green shoots, we've got a long way to travel here, of the consumer in some of these spaces. We have the quantified self emerging in various ways. Sadly, perversely but positively, we have chronic disease, meaning that people aren't just an occasional user or episodic or emergency user of the healthcare system, they become frequent travellers, they become more sophisticated. We've got nascent data transparency. The work of Deborah Picconi's Safety and Quality Commission is a signal piece of contribution in this regard. And interestingly, at a policy level, we've got things such as the NDIS, which represents a bit of a wooden horse in some of these policy areas because it's been deliberately framed to be patient-centred with all sorts of risks around that, but nevertheless it's going to be operating and developing in stark contrast in terms of operating model to many of the other delivery systems in social and human services.
Thank you, Rowan. You've raised a lot of important points, complexity, the workforce, But before we explore those more broadly, I'd like to invite you, Bessie. So you talk about, you look at the world that you operate in, social enterprise, entrepreneurship. We use the word innovation. How do you, to what extent, one, will a market like this attract more enterprising innovators, enterprising individuals and innovation, do you think? And how would that need to work?
Sure. I think one of the things that's interesting, if you take Stephen's comment around a user choice approach and needing to first actually design an environment that empowers those people to be ready to engage in making those decisions. I think the same thing happens at the point of looking at a social sector, for example, that we're wanting to be more innovative or to come into these types of competitive situations. There are things that we have to do and address with the social sector before they are able to properly engage in innovative ways or in commercial ways. Some of the things that are worth keeping in mind in terms of a context piece is that from a social perspective, so organisations that are typically a charity or a not-for-profit or coming as a service provider, they tend to have a mindset that I refer to as a scarcity mindset. So they are used to operating in an environment where there are limited pools of funding available to them, where actually, with another use of the word competition or competitive, it's actually very competitive in a charitable social sector, but in more of a desperate way than an empowering way. And I think we have to acknowledge that there are power dynamics and business models and funding models that are so entrenched in the social side of the equation that actually drive bad management practice or business practice. We're not allowed from a social sector to actually build up a buffer or have excess money in the system. We're encouraged to, you actually are punished if that happens and you need to give money back to a funder. And so it drives a whole stack of bad behaviours that actually aren't conducive to encouraging people to be taking risks or pushing boundaries in some of those things that we might think of as innovation. The other aspect I think that's quite interesting when you look at some of the components around driving towards innovation is that on all sides of this conversation, I think people misunderstand the actual conditions that bring about innovation. So we have lots of conversation, whether it's from a social sector side or from a commercial side, saying we need more money in the system, or we need tax incentives or other things to drive innovation. There was an interesting article in Fast Company in February this year that had a beautiful quote where they said that innovation typically doesn't happen in the cradle of deep pockets. It happens at companies with limited resources that need to solve problems fast or close shop. And I think one of the tensions when we talk about innovation, wherever you're coming from, is to actually acknowledge that the old aspect of necessity being the mother of invention is still true. And we need to be aware of not putting too much money or too much of the things that incentivise wrong behaviour into a system, and then hope we'll magically get these vastly different solutions that actually have a chance at cracking big entrenched problems that we have in our society. So I think that aspect of innovation is worth keeping in mind. We need to balance having enough runway. You do need, from whether it's a social entrepreneur or a general entrepreneur seeing opportunity and coming into this space, you need to have enough runway and comfort that there is money in the system if you deliver good outcomes. That needs to be in place for people to want to play. But we don't want to end up just having what gets engaged with as buckets of free money in a space, because I don't actually believe that that will lead us to the kinds of things that if you go to the NDIS or other places where there is this grand and honourable intent to try to create better outcomes for people that are in difficult situations, and that is trying to drive not just that better outcome, but a more efficient and effective way of dealing with a problem. The design component of what we do with our policy, with our funding, with our interventions is critical, and having an eye for designing that in a way that incentivises the right behaviour, I think, is a much broader conversation and far more complex and nuanced than people are actually having at this point.
Thank you. So let's assume that with competition, contestability and user choice, what we're looking for is the evolution that followed the Alexander Graham Bell model, not necessarily the Florence Nightingale model, if we really want to make an impact. So from your perspective, and I'll open it to either of you, where do you start? I mean, you've raised, all three of you, what do you start with? Stephen?
I think it's really important to recognise that there's two different parties that need to innovate, at least two different parties, in human services. The first we've really talked about is the providers, and the providers have to have the incentives to innovate, and that's one of the reasons why I like user choice. Nothing like saying, well, gosh, I'm only going to get the resources if I actually meet this person's needs, to make me think about how can I better meet that person's needs in a better way. And we're seeing some examples of that where you have private sector in health. So apps to remind you of your medicine, which some of the more innovative pharmacists have rolled out. Simple example, most of you will have seen Webster packs, multi-dose administration aids, as they're called in the thing, basically bubble packs where you have your day's medicines. Any of you have an older relative, you'd be aware of them. That was an innovation by a provider. It was an innovation by what's now called Webster Care. They brought it back from overseas, quickly got copied, is now provided. Go to any retirement home or old age facility in Australia, you'll see them. And a whole bunch of other innovation, by the way. So that's innovation by providers. The other party we need to think about is innovation by the government, because without government innovation, without government thinking, how do we do things differently? How do we create the space? How do we create the incentives for innovation? Nothing is going to happen. If you simply set a set of rules and the government says, well, you can provide the services within those rules, or even worse, we have a government mandated monopoly provider and they provide it, full stop. There is no incentive for innovation. Let me pick up on the phone example. I'm old enough to remember the bad old days before we actually had some phone competition. Came back from the US in the early 1990s. Those of you who remember the early 1990s, it had gone out of the Postmaster General by that stage, but we had Telstra, or Telecom Australia it was then known. We didn't have any competition. Came back from the States where there was a competitive market and got back to Australia. Couldn't use any of the equipment we'd brought back from the States because according to the rules, none of that was allowed to be connected to the Australian telephone network. Still had, in the house that we rented, a dial phone. My daughter's a primary school teacher and she said, yeah, we did the ABBA Ring Ring song. And the kid said, why do we do that when you say ring ring? Why did we get change there? Because the government allowed change. The government allowed innovation. And without the government itself innovating, the providers can't innovate. And I think that's the key starting point.
Could I add to that? And I don't mean to weigh this down with potentially cynical observations, but the danger also is that providers and governments remain in quite comfortable relationships. And historically, in some of these sectors, that has actually served the community potentially reasonably well. If we think about the rise of the welfare state post-Second World War, and we think about some of the achievements in relation to inequality and social outcomes, we've got to put some credits at that door, I would have thought. I think the danger is now that habit of a lifetime may no longer be useful. In fact, it could be very, very expensive and ineffective and ultimately disempowering and problematic for community amenity if we let that continue. So, for example, in healthcare, we see it sort of as I think Martin Parkinson observed last night. It's just a collection of provider interests. There is no consumer in healthcare. There are many providers who say they are the voice of the consumer, but there is a relatively weak consumer voice. Inga Clendenin sadly passed, but one of our nation's ornaments to literature, in undergoing a liver transplant in Adelaide, made the lucid, limpidly clear observation in hospital. I soon learnt it was the vertical people that had all the power. So we've got to change some of these things.
I think there's also an aspect, if you look at government, for example, that what tends to happen is, I think, due to a loud voice that acts as if the financial mechanism or components of how we fund things is the tricky piece, we tend to push our attention to money and structures and investors, or those with power, and yet I would say that at the aspect of government innovating, if you look at, say, something like an obsession with social impact bonds, actually the innovation is a payment by outcomes approach. Having conversations obsessing over the financial mechanism of a bond is irrelevant, and actually, despite the fact that people try to act as if that's the complicated piece, that is easy. Financing something once you have designed and structured it well is not a problem. There is plenty of money out there in the market looking for places to invest in things that make sense. What we need to do is have government actually driving real clarity around what are the outcomes that we want to see achieved, how will we measure and know if they have been achieved, and what are we willing to pay if they are achieved. It's that simple/complicated. That is the conversation, and yet we obsess over and focus on and spend our time and money on the piece of the equation that is actually very basic and sequencing-wise should come last. So that is a place for government to really step up and show leadership in that payment by outcomes piece, and then the next sort of stage is actually to say, we have to take sequencing into account. You can't, it does matter what order you do things in. And we have to really look at the context and properly understand the situation we are trying to have an impact on, and say, what is the capacity of a service provider to actually engage with the NDIS? We've been doing a pilot work around NDIS readiness. The NDIS at the intent level is an incredibly powerful thing, and I really want to see that decision-making and autonomy and respect being handed to those in terms of the title of user choice kind of category. I want those participants to have that. But the work that we have been doing with providers says that actually you're starting from a place where people have never had to engage with someone as a customer. They don't know how to actually properly understand and do personas about what is it customers are looking for, how should I communicate my services and offerings and what they cost. There's a stack of work sequence-wise that has to happen before you can jump into the implementation of a very different approach. And I think that combination of payment by outcomes focus and then sequencing and properly addressing, we have a demand side issue, not a supply side issue. There's not an issue with capital. There is an issue when people say access to capital is our biggest problem. The word you should focus on is access. They can't access it, but there is capital. Putting more capital is not the answer. It's a demand side problem.
Very thought-provoking where you've left us, Bessie. I'd like to open the room to questions. So we have a person there, and if you could say your name and just wait for the microphone, that would be fantastic. Oh, okay, up there. The microphone will come back to you.
Oh, Sue Ash from Uniting Care West in WA. I'm particularly interested in the comments around outcomes, and I agree with you, Bessie, around the imperative for those changes. The challenge that I think we've got is the interface with our government structures, and by that I mean we're invested in a Westminster government system. We talk whole of government outcomes, but we manage government processes through portfolios. I'm really interested in your views, or any of the others, panellists' views, about how we bring our government processes into the 21st century so we can actually do this. And I'm not in any way, shape or form thinking that this is the one key factor, but I do think that it is a really difficult thing to do, either as a consumer or a provider, to try and get those changes in government processes.
I think in many respects it's an aspect of taking a designerly approach to something, which is to say that we will not, whether it's from a government point of view or anyone else, we're not going to get it right the first time. You can't spend all your time and money designing the beautiful end product and think that when you put it into a market, it will work. And I think one of the things we need to encourage in our interactions with government is to say, let's test, let's do a little bit, let's actually figure this out together, knowing that it won't be right and that we're going to have to refine and iterate over and over again. They didn't come up with the total transformation in a phone by getting it. It didn't jump straight to this. We didn't, get it right the first time to the level that it is now. And I think engaging with government to try to gradually change ways that they are procuring or commissioning work is important, but starting to, where you can, have more of a say earlier on in the design of how things work, but then setting things up where you can actually properly test something, refine it, redesign the business model where necessary, and iterate, and not see that as a failure, but actually see that as a brilliant and much more efficient use of, in terms of stewardship. That is a much better use of resources than going big bang, then being disappointed that it didn't work. So I think encouraging government around that type of approach is one way. I know it's frustrating and slow, but I think that we need to see that come into the engagements with government more and more.
Stephen, you.
Yeah, I really want to back that up. The missing word often from reform, not just in human services but generally in Australia, is transition. And if you don't, it's fine to say, and I'll pick on the NDIS, it came out of a Productivity Commission report, and if you go back and look at that report, it was a much slower transition process, much more testing, much more rollout slowly than what has actually happened. And I guess there's pressures for governments to roll out things rapidly, to try and get to the end point quickly. But that sets system changes up for failure. And no better example than the one that gets tossed around all the time, the vet failures, the vet reform failures there. It's not that those reforms were fundamentally flawed, that they were a stupid idea, but the idea of allowing private providers in without appropriate accreditation when the government is paying for upfront for the students under a loan scheme where most of the students will probably never earn enough money to pay back, so it's free money for everyone except the government. That was the system where if they'd done it slowly, if it had transitions, if it had more trials, if they'd tested it, rather than going down that rapid change approach, I suspect it would now be far further advanced, it wouldn't be being rolled back, and instead of being a failure, we'd be calling it a success.
And I think that's for instance of a mindset that goes to a policy activity outcome versus an outcome. And just in response to your question, I think too often when you approach government and you establish an arrangement, there is the real danger of the faster horse. We're going to contract out in a slightly different way. We're going to, but in some ways, because of risk aversion, habits of a lifetime, we end up largely in trying to ape some sort of world that we currently know. I think the really challenging thing for government is to contemplate a world that they don't recognise and understand. And how do we build up in government techniques and capacities to commission on a basis where for the unimagined. Surely that means, for me, practically, that means you have to go back to the participant, the client, the patient, and make them the centre of the measurement activity. And you have to go to outcomes, not processes, which too often are much easier. I think on Bessie's point before, we obsess about the nature of the technical issue of a social impact bond and whether it's got proper tax forgiveness or it's neutral in this regard or that regard. You know, rounding error, but it's human nature. We focus on the complex issue rather than the adaptive change issue. And I think that's what we're sort of talking about.
Thank you. Now, we've got a question here.
David Puller from Roche Pharmaceuticals. I'm interested particularly in the discussion about contestability and user choice in healthcare services. And as a former student of Professor King at Melbourne Uni in introductory microeconomics, I learnt about the concept of information asymmetry. It's probably the only thing I remember nearly 20 years later. But I do remember that. And
Well, that's impressive.
in healthcare, we do see a lot of examples. There's some ways in which patients don't have enough information. They demand information, they want information. Maybe there'll be some things they can never learn without full medical qualifications. But there's other things where there's regulatory imbalances, and we see this where, for example, a patient can watch Today Tonight or whatever and learn about some sort of miracle cure which is completely untested and regulated, and yet the information about pharmaceuticals or medical devices or surgical things that are, the gatekeeper is the doctor. And they often have to be given a whole list of the downsides as well as the upsides. So what do you see as some of the ways to, I guess as a panel, of if we want more consumer choice, if we want to empower people to be more active participants in their own care, how do we overcome that? Or is it, Professor King, one of your examples is saying maybe there's some things where we can't expect user choice. Where does this sit on that continuum?
Happy to respond to that first. The information part is critical in user choice. If users don't have the appropriate information, if they don't have it in a form that they can understand and make decisions based on, then there is no informed user choice. They'll be making decisions according to Today Tonight rather than what is actually a desirable outcome-based approach. There's numerous ways to approach that. So in healthcare, for example, we've got the experience of the UK, where they've moved over time to a requirement for GPs to provide more information about specialists, where there's a move, which we're seeing mimicked now in Australia with the private health insurance funds, to actually rate hospitals and to say, well, these are some metrics of hospital performance that will be of interest to patients, and patients can make decisions based on those. In the UK, the evidence seems to be pretty clear, as far as I can tell, that they have led to improvements in the healthcare system, partly driven by the specialists and the hospitals themselves. You know, no one wants to end up down the bottom of any one of those rating lists. So even to the degree that the patients still are getting only partial information, and you may say, gosh, that's crude information based on a couple of metrics, it leads to changes in behaviour of the providers that have been useful. Another example, we had Western Australia up there. Western Australia is actually doing a couple of different NDIS trials because Western Australia have had what they call individual care packages, for over a decade now. And part of their approach is to have a local coordinator. So if someone, let's say Bessie, is getting a package, the first thing that happens is a person with no conflict, they're actually a government employee, sits down with Bessie and says, Bessie, what do you want to achieve out of life? Where do you see yourself in 5 years? What are your objectives? And that's where the conversation starts, so that person can help make sure that Bessie has the information that she needs to be able to make the choices. So that's part of that stewardship role. It's part of the design role to make sure that the information's there. But yes, sometimes, back of the ambulance, I really am not going to care too much about the information.
Yeah, look, I think there are some really important issues to do with information asymmetry, and there are some egregious examples in relation to both inappropriate use of patient information that's partial and poorly constructed, and similarly on the provider side. And I think it's important to say that because they exist, and they're often led by clinicians and other stakeholder groups. Having said that, I think it's important to be very, very assertive in not letting that important terrain dominate the whole agenda, because it is a relatively smaller domain of real issues. On average, you provide more transparency and more information in some of these areas, and on average, you get very important shifts in consumer behaviour, and as Stephen said, you get some real changes in provider behaviour. If I go to, it's been too long in the waiting, but we finally have version 1 and 1.1 of an Atlas of Healthcare Variation in this country, produced by the Safety and Quality Commission. And therein you discover that, and sorry for the crude terms here, but just to make a point, because this is how serious it is, if you are a woman in the Hunter region of Australia, do not fall asleep at the wheel of your car, because you might wake up without a uterus. The rates of hysterectomy in certain catchments in Australia are deplorably, unconscionably high compared to OECD global averages. And we didn't know that. We didn't know that in a public way. We now know. Similarly, if you get off a plane in Adelaide, your chance of getting back on the plane with a knee arthroscopy are 7 times higher than anywhere else in the OECD. And we didn't know that. And we need to know that, and we need to start asking people who are in enormously privileged positions in terms of information asymmetry to actually proffer the scientific bases for some of their interventions and actions, and then have a dialogue with patients, in this case, as real and whole human beings.
Are there any more questions? Just the microphone is coming, or it's coming from here.
Thanks very much. Can you hear me? Yeah, it's
We can from here.
Rupert Timms from Fragaman. Look, as we move to user choice, and as the health and aged care sectors in particular ramp up, as I understand, is expected over the next 5, 10 years and so forth, I'm just wondering what the panel thinks that the role of migration will be, immigration, and because obviously we'll need a larger workforce in those sectors, and will it be, if there is a role, will it be for skilled or highly skilled people, or will it be for semi-skilled people, or both? Thank you.
Well, just sort of from a provider perspective to start, I'm sure there'll be other more global perspectives. When we look ahead in terms of healthcare and social assistance, the broad area of activities, we see in areas like aged care, elements of community care and health and so on, something like 1 million net new workers needed over about the next 10 years, net. And when you think about the sort of average age of the working nursing workforce in Australia, for example, being in their 50s, and you think about what that means in terms of flows into the system, that's very significant. But additionally, and you raise the issue of skills and semi-skilled or highly skilled workforces, if we have the rates of diabetes and the logical consequences for kidney disease, the number of nephrologists we need in this country sort of goes off the charts. Right? So that's an example of just one, for instance, that demands sort of adaptive change. So that's it, sort of in the clinical workforce, and we'll have, and things will change. Modes of care and so on will respond differently. But I think one of the really interesting conversations we potentially need to have as a community is that we also need laundry folk, personal care aides, etc., semi-skilled and lower skilled and entry-level care working positions. Subject to interventions, as a nation, we'll have more people living with dementia in about 7 years' time than we have Tasmanians, and we're going to need to work on how it is that we support that volume of our population. Now, hopefully there'll be some interventions on that curve, but that's the sort of prospect that we're facing when we reflect on workforce. So have we had a conversation with the community about the potential need for a labour migration program as opposed to a skills migration program? Now, I don't think we have enough information today to really chart that conversation, but I sense that it may be an important conversation that we need to have.
I think part of the challenge is that in that exact issue of being able to answer the question, you need access to information and data that gives you the insight into actually understanding where that need is and the ramp-up rate of at what point we need different things. On the level of skills not at that higher end, in the NDIS readiness work that we're doing, where we sort of have three categories that we're working with: the executive, the management, and then frontline workers. And in the frontline worker category, one of the biggest issues being raised is the high number of people that are in that category where English is a second language. And so there are absolutely issues going on in different components that I think we have to properly get our heads around to then figure out how to either attract the talent we need, how to then train and equip them so they're ready to engage effectively in this, whether it's aged care or the disability sector, whatever area it is. We have to then properly make sure we're ready to engage with those people at any of those levels. But a big part of that comes down to the information available and then the people who are able to think about it at a broader level and structure up what's needed.
Are there any more questions from the audience? I was just going to, while we're waiting for the question, it got me thinking. I was in Paris last week attending a global government conference within EY, and one of the people from the US was saying that in the US, apparently, most of the truck drivers are over about 50-year-old men. And if you think about jobs of the future, driverless vehicles, then you think about that workforce and where will they go. And certainly and the other comment was, no one's really focused on the societal needs. Like, everyone's focused on the shift out of their organizations or into their sectors. But who's worrying about society? And I think that Australia does worry about society, and I think there are a lot of opportunities for us to think about where will that workforce come from, and they might be in our country as well as in our neighbouring region.
I think the truck drivers will go back to university studying to be lawyers to deal with all the claims that will come from driverless vehicles. My question is about delivery of health services more particularly, and difficulties across jurisdictions. Does the panel believe we are any closer, whether it be not necessarily just talking about adaptive technology, but business models where consumers can be confident that if they move across state boundaries, that the level of resources and the competency and the quality of individuals and the advice that is given to consumers who need advice around healthcare, and I'll use mental health as an example here, are we any closer to getting some standards and some standardisation of practices where consumers can feel comfortable about moving from state to state?
Stephen, I think there are reasons to be cautiously optimistic on this front. If I could again go to the National Safety and Quality Commission in healthcare, they have done a sort of monumental amount of work that has brought stakeholders along to actually progressively publish by way of sector involvement, engagement, testing, so on. They have published an extraordinary body of standards of conduct, everything from in relation to hand washing, to labelling on medicine jars, through to the conduct and response to deterioration of someone's mental capacity in hospital, etc., etc. It's an extraordinary ambit, extremely complex, sort of nuanced agenda, and they've made enormous progress. Having said that, the system that we are dealing with, and you don't need to cross state boundaries, in truth, you can walk into the Australian healthcare system and you can have, no matter what your condition, you can potentially have some of the best, bar none, healthcare in the world. You can have truly amazing treatments, responsiveness, appropriateness, etc. The sad truth is that you can walk into the same healthcare system on a different day or through a different door, and you can have some of the worst experiences. You know, and without overblowing it, we've got sad, for instances, in relation to whether it be Bacchus Marsh or antiseptic, wrongly read as anaesthetic for a lumbar injection. We have, sadly, we have conjoint twins, Siamese twins, being separated after 26 hours of surgery in some of our Sydney hospitals, and at the same time we have people miscarrying in waiting rooms. So, you know, it's, for mine, the sort of the approach I bring to it is, you know, okay is the enemy of great, and how do we try and make this system self-aware and self-improving enough to really strive to wash out those minority of unacceptable cases and experiences. And sadly, you don't need to cross a state boundary to have a different experience.
Well, I could continue this conversation, but I know there's morning tea waiting for everyone. So, Rowan Mead, Bessie Graham, Professor Stephen King, very enlightening, thought-provoking conversation, much more dialogue to have beyond today, but thank you very much, and please join me in thanking the panel. Thank you.